This is case L3 CT A54. The history is that of a 66-year-old woman who's had some chest pain, but has a history of atrial fibrillation, and the examination was ordered by the electrophysiologist primarily for preoperative evaluation for pulmonary vein ablation therapy. We commence with general review of the study. This was a prospective study, therefore we have no evidence, no information on left ventricular function, and we only have the high-resolution coronary images. Beginning at the base of the heart, the aorta appears to be of normal size next to the pulmonary artery. The thoracic aorta does show some mild mixed calcified, non-calcified plaque. As we move down, one of the important features, in particular in individuals who are undergoing the potential for pulmonary vein ablation and assessment for previous atrial fibrillation, is to get a good assessment of the left atrial appendage. This is the left atrial appendage, but one of the concerns here is that you can see the outline of the appendage, and this is certainly darker in the more apical portion of this appendage. Left atrial thrombus formation is not uncommon in such individuals, and CT is very helpful in ruling out the presence of left atrial appendage thrombus, but is not particularly good at ruling it in. One method to assess whether or not there's any flow in this area that appears to have reduced function and opacification is to specifically examine the density within these regions. If we examine the CT density in the clearly opacified regions, we're seeing a mean density of about 477 Hounsfield units. If we use a similar region of interest in the area with the reduced density, we see a mean density of about 95 CT units. A true thrombus in the left atrial appendage would likely have a CT density that would be closer to that of clotted blood, which would be on the order of 20 to 30 Hounsfield units. Finding a mean CT density of 95 Hounsfield units suggests that there is some flow in this region, and so therefore this could be representative of what's called a pseudothrombus. Proceeding further caudad, as we go down, here's the left atrium, which may be mildly dilated. We can make a direct measurement of that. It's about 40 millimeters, so therefore it's borderline at most in terms of overall size. Moving on down lower, this is the esophagus. Appears to be somewhat dilated as we get down into the lower regions. Another important thing to look at for patients undergoing assessments for electrophysiologic examinations is to get an idea of the pulmonary veins. This is the right superior pulmonary vein, and orthogonal to that we can see also the left posterior inferior pulmonary vein. Measurements can be made of these structures in a variety of ways, but there are two left pulmonary veins. Same assessment can be done by looking at the pulmonary veins on the right side. This is the right superior anterior pulmonary vein. And as we put this in a more orthogonal view, you can see that there are actually three pulmonary veins: a right anterior superior pulmonary vein, a small right middle pulmonary vein, and then a right posterior inferior pulmonary vein. One important assessment for the electrophysiologist is to determine the location of the esophagus as it relates to the pulmonary veins. Here's the esophagus. We're going to go somewhat cephalad. This is the esophagus over here, and here is the right posterior inferior vein. So at this level, there is no concern for the potential for a catheter inserted in the right posterior inferior pulmonary vein to potentially have a problem related to the esophagus and the exterior regions. We now need to look at the coronaries. Here is the left main coronary artery. It appears relatively normal in its proximal segment. As we get down into the distal segment, though, we can see extensive calcified plaque, eccentric. We try to debloom it by expanding the the viewing window. And if we look at this in this oblique view, this really suggests nothing on the order of obstructive disease, so that's eccentric, non-obstructive plaque in that region. Let's look at the LAD as we proceed down. We can see eccentric calcified plaque in the proximal left anterior descending artery. Again, as we go around, it appears to be perhaps maybe this is more concentric than eccentric, and we try to use an MPR to separate in that area. This is borderline moderate to equivocal obstructive plaque in the proximal left anterior descending artery. Proceeding down the remainder of the vessel, there is also some plaque at the bifurcation into the mid left anterior descending, and there is spotty calcification in the small diagonal. There also is a probably non-obstructive disease at this juncture in terms of the mid left anterior descending. Now examine the circumflex artery. This appears to be generally normal. There really is basically a large vessel coming off. It's sort of in the direction of what might be consistent with a ramus intermedius branch, but then comes down and bifurcates. There may be some trivial disease in the section of this vessel that would be called the OM or the ramus, but otherwise appears to be normal. The circumflex body of the circumflex artery is otherwise quite small. This is review of the right coronary. The ostium appears to be normal, but in the very proximal portion of the vessel there is some eccentric calcified plaque. Switching to an MPR view suggests that this may or may not be obstructive. It's sort of equivocal in terms of its overall extent. Looking at the remainder of the vessel, there also is some additional potential narrowing right here in the proximal portion with non-calcified plaque. Sometimes switching to another phase can be helpful, but this is not quite totally clear. There also is some calcified plaque in the mid right coronary artery. This appears to also be somewhat equivocal with respect to whether or not this could be obstructive. There's some blurring, and there's very little else I can do with respect to that. So this was a prospective examination. The remainder of the vessel continues to demonstrate some mild plaque. As we get down into the distal segment, it's quite normal, and the posterior descending appears to be a normal vessel. So in summary, we have a 66-year-old woman who's had some chest pain, undergoing evaluation for pulmonary vein ablation. We have no evidence, no information on left ventricular function. Her left atrium appears to be borderline to mildly dilated. There is a concern of a thrombus or pseudothrombus in the left atrial appendage. There are 5 separate pulmonary veins, and she has evidence of diffuse and possibly borderline or equivocal obstructive disease in the left anterior descending and in the right coronary artery.